It's recording. Thank you, Kelsey. Okay, slideshow. Beginning. Okay, so can you all see? You see electrical
Yes.
conduction disorders.
See your PowerPoint page.
Okay, okay. So just to review the cardiac conduction system, cardiac dysrhythmias, they used to call it arrhythmias, now they have switched to dysrhythmias. So dysrhythmias are just abnormal rhythms of the heart's electrical system, or in simpler terms, it's just heartbeat disturbances. That could be beat formation, beat conduction, or the heart's response to the beat. And it affects its ability to effectively pump oxygenated blood throughout the body. Dysrhythmias can result from disturbances from cardiac electrical impulse formation, conduction, or both, and dysrhythmias can be life-threatening. So when you think about it, when the heart does not work effectively as a pump, because that's what the heart is, it works as a pump, you have perfusion to vital organs, and peripheral tissues can be impaired. And then that will result in organ dysfunction or even organ failure. So some causes of dysrhythmias, many diseases can cause dysrhythmia, such as coronary artery disease. We talked about electrolytes, specifically potassium. Any abnormal potassium can cause cardiac problems. If you have a change in your oxygenation, or even drug toxicity, that can also cause dysrhythmias. Dysrhythmias can occur in any people of any age, but most often it occurs in the older adults. To provide patient-centered care using our best practices, it's good to have a basic understanding of cardiac electrophysiology, the conduction system of the heart, and then the principles of electrocardiography, which is your ECGs, your EKG. So this slide just tells you kind of what is included in the conduction system. You have the SA node that is in the atrioventricular junctional area, and then that's what shows up as the P wave on the EKG. Then you have the, the SA node. That's where all the conduction begins. And usually it will send impulses 60 to 100 beats per minute. Then it goes to the atrioventricular junctional areas. There's like a short delay between, that S1 and that S2, allowing the atria to fill, to contract, and the ventricles to fill. And this contraction is known as the atrial kick. It gives additional blood volume for a greater cardiac output. Then you have the bundle of hits. I don't want you to spend a lot of time thinking you need to remember this, because this again should just be a review for everybody from your anatomy and physiology class. So this is showing where the leads are put for an EKG. An EKG provides a graphic representation, kind of a picture of your cardiac electrical system. So one lead provides one view of the heart's electrical activity. Usually when patients have an EKG, it's called a 12-lead EKG. That's standard. So in a 12-lead EKG, there's 12 leads using 10 electrodes. They're hooked to the limbs, and they're also placed on the chest. More information is on page 666, table 34-3. So you see there's 4 leads, 2 on the arms, 2 on the legs, and then the other 6 leads are placed on the chest. And I know many of you, I know my students at Grove that went to ER, many of you had a lot of experience putting on leads. So hopefully if you didn't get that experience, you will get that at some point. So let's think for a minute, what diseases or conditions do you think a patient might have that they would get an EKG for? Kathleen, you'll have to read them off if anybody types anything.
AFib.
Shortness of breath.
Good, shortness of breath. Any more? A lot more out there.
Chest pain.
Chest
Chest
pain.
pain,
AFib,
MIs,
flutter.
A flutter, good. What about electrolyte disturbance? Remember potassium? Anytime you have an abnormal potassium, you've got cardiac problems.
They'll also do it for MIs.
MIs, very good, very good.
Lightheadedness.
Lightheadedness, dizziness, syncope, good. Kidney failure, lung disease, shock, pericarditis, all those would call for an EKG. So when you put these electrodes on, you want to have your patient lie still. If there is a lot of hair in on the chest, you don't want to shave, you want to just try to clip the hair away. I don't know what they had you do in the ER, but according to Iggy, it's not recommended that you shave the area, you just clip the hair away. And you need to make sure the patient knows that an EKG is just going to give them a picture of their heart. It's not going to pick up whether they're having any pain or they're having any shortness of breath, anything like that. So just make sure your patients understand that. Usually respiratory therapy will get most of the EKGs. I don't know if they do in the emergency room, but up on the hospital floors, they're usually the ones responsible for that. Okay, any questions about this so far? So included in an EKG, and like I said, this is going to be very basic. These are the different complexes, segments, and intervals that will be shown when a patient has an EKG. And so then this just kind of explains what a normal EKG looks like. I'm not going to break it down. It would take too long. I just want you to kind of know, there's a PQRS. And I just kind of want you to know what a normal EKG looks like. Susan will go into much greater detail next semester, or I think it's 3rd semester. And
I think that's right.
she has calipers, I think is what it's called, and that's how you measure the segments and the intervals on that. And she'll go in a much deeper depth on how to read the EKGs. But what we are going to do, we can determine a rate by looking at an EKG. And so you'll see how these little squares are broken down into times. And so each small, you see the bigger square here. Let's see. Let me see if it'll let me do it. Draw. Okay, see this here? No, yeah, it's doing it. I watched a video last night on Zoom and I learned how to do this. I thought I would impress Kathleen. So each of these squares is 0.04 seconds. And so 5 of these is 0.20 of a second. Then you have to erase it all. Or clear it, clear, there we go, clear. If you don't clear it, it stays on the next slide. So then when we're looking, let me get rid of that. Then, so now that we're looking at this slide, you'll see that these marks here, There's a mark here and a mark here. And so there's that represents 3 seconds. And then this next here represents 3 seconds. This is the most common way to count the rate. So you're going to count the QRS complexes in a 6-second period. And so the QRS complex is these points right here. So you're going to count those, and there's 9 of them in a 6-second interval, and then you're going to take that number times 10, and it's going to give you the heart rate. So this heart rate would be 90. Okay, does everybody understand that? And I don't want you to get too caught up in this. So what it is if you count, each little square is 0.20 of a second. And so if you count 15 of them, that makes 3 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So every 15 squares is 3 seconds. So you're going to count it for 6 seconds. And there's 9 QRS complexes. And then you're going to take that times 10. So this heart rate would be 90. Okay. So when you learn how to do an analysis on EKG rhythms, these are the different things that you are going to determine. You can do heart rate, heart rhythm. You're going to look at the P waves, the PR interval, and so on. And again, that's called a caliper. Is what that it's. I'm trying to think what to tell you what it looks like. The little metal thing that you put a pencil in on one side, and then the other side has like a point, and you put it in the center of a piece of paper, and then it would draw a good circle. That's kind of what a caliper looks like. And
Is
Susan,
that a protractor?
yes, very good. Yeah, thank you. Susan has those for you to use next year. We're just not going to get into it that deep. So other than an EKG, there are also other continuous cardiac monitors that patients can have in the hospital. And I know a lot of you have already seen telemetry. And the telemetry units only have the electrodes that go on the chest. If you put them on the arms and the legs, you know, you want your patients to get up. You don't want them just to lay in bed the whole time they're in the hospital. All that motion and everything it puts a lot of artifact on the EKG strip. So the electrodes are just on the chest for a telemetry. So they're monitored 24 hours a day in the hospital. They can walk around. Obviously, they can't leave the hospital with it or it wouldn't work. But anyway, a lot of patients have telemetry. And again, you want to make sure your patient understands it's not monitoring for shortness of breath or chest pain or anything like that. So if they experience those things, they need to go ahead and report it. All it's doing is monitoring their heart rate and rhythm. And then if you take care of a patient that has telemetry, you will usually call once a shift, see what the rhythm is, and get what the rate is, and you document that in your nurse's notes. Then there's also a Holter monitor, which is a monitor that they can wear for 24 to 48 hours or longer, depending on what the doctor wants. They go to the hospital, have that put on, then they go home. My mom had to wear one because she was having severe bradycardia. So every time she had chest pain or she felt like her heart was slowing down, there's a button you can push on it and it puts a little marker on the EKG graph. So then when your doctor reads that, he'll see those marks, and then he'll know that something happened at that time. And so he would look at it maybe at those times a little closer. So those are two other ways that the heart is monitored. other than just an EKG. So let's talk about rhythms. A normal sinus rhythm, the rate is 60 to 100 beats per minute. We're not going to talk about the P waves, the PR interval. That's just some extra information there. So that's just a regular rhythm. And if you see an EKG that looks like this is a normal sinus rhythm. So since we've already talked about the rate, count the QRS complexes, take it times 10, and what do you think the rate of this EKG is? Anybody have a guess?
80.
80, good. Yeah, because there's 8 QRS complexes in that 6-second period. You can see the little lines at the top of the EKG that's marking that 6 seconds for you. And you just count the QRS complexes and there's 8. So it would be 80. Now, not all normal sinus rhythms will look like that. This represents 2 kind of different looking sinus rhythms, but they're both normal. They're both sinus rhythm. So who can tell me what the first rate is? The first one is sinus tachycardia.
$12.
12, so it'd be 120. And then the bottom one is going to be a bradycardia. And so what?
60.
50.
50.
Bradycardia.
Yeah, there's 5 QRS complexes there. So it would be 50. Very good. Okay, so let's talk about a sinus arrhythmia. This is a variant of a normal sinus rhythm. In this term, usually when you have A in a word like arrhythmia, you would think it means an absence of rhythm, but that's not what it means. It just means it's an abnormal rhythm. Okay, so sinus arrhythmias, these are seen a lot in healthy adults. A lot of adults don't even know they have them. Occasionally, they are due to medications like digitalis or morphine, but usually sometimes they're caused by slightly during inspiration, when you have your heart rate increase when you're taking a breath, and then when you exhale, it can also vary during that time as well.
Somebody asked the question, do you not count the line in the middle when you're counting the rhythm?
Let me show you here. So for, let's do the bottom one here on B. So this would be 1. This would be 2. 3. This is kind of hard to write with. 4 and 5. So see, this one, this happens after the 6-second mark. You're going to count between that mark up there and that mark there. Does that make better sense? So it would be 50.
I think it's the drawing's off a little bit somehow, so it's kind of confusing.
Yeah. And again, don't get too caught up on it. You're not going to be given a strip and ask what the rhythm is. We're just wanting you to be familiar with the basics of the EKGs and looking at them. Okay, so again, any disorder of the heartbeat is called a dysrhythmia. Dysrhythmias occur for many reasons. Again, MIs, electrolyte imbalances, hypoxia, drug toxicity, low blood volume, use of illicit drugs, stress, fear, anxiety, you know, the list could just go on and on. So we can have premature complexes, we can have Brady dysrhythmias, and we can have tachydysrhythmias. Sinus dysrhythmias are sinus tachy, sinus Brady, and then this is a sinus tachy EKG strip. The rate on this one is 110. Tachycardia is defined as a heartbeat that's greater than 100 beats per minute. Usually it does not go over 160. This would be a normal response to physical activity, maybe to anxiety, pain, stress, anemia, hypoxemia. Also, medications can cause sinus tachycardia, epinephrine, atropine, caffeine, different things like that. Treatment for sinus tach, there's really not any treatment. If it's medication, you would want to either stop the medication or maybe have the doctor switch it to something else. Obviously, if it's physical activity, you would stop that activity. You would just kind of treat the underlying cause. There's no real treatment for sinus tachycardia. Now, sinus bradycardia is a heart rate that is 40 beats per minute. So this is a little more serious than the sinus tachycardia, because anytime your heart is not beating as well, your perfusion is going to be less. Now, many patients are asymptomatic that have bradycardia. But then some patients may have syncope, dizziness, weakness, confusion. They may have symptoms. So if you have a patient that has bradycardia, you may push some IV atropine. They would probably be getting some IV fluids, be getting some oxygen, and then possibly a pacemaker. So let's talk about pacemakers here for just a minute. Placement of a pacemaker is on page 675 in your IGGY book. There are temporary pacemakers. They can be invasive or non-invasive. And then there's also permanent pacemakers. So some indications for a pacemaker obviously is going to be the bradycardia. If a patient would have a heart block, maybe if they go into sinus arrest, any dysrhythmias and such like that. A pacemaker, it is operated by a battery, and what it does is it electrically stimulates the heart when the natural pacemaker in the heart, which is the SA node, when that fails to maintain an acceptable rhythm. There are electrodes that are wires that attach to the myocardial muscle on one side, and then they connect to the pulse generator on the others. And so you may, probably most pacemakers are put in on an outpatient basis now, but just kind of need to be aware of them. A temporary pacemaker is an energy source that's provided by an external battery pack. The battery pack is actually on the outside of the chest, and then the wires are threaded down into the heart. And sometimes they'll use these if a patient maybe is waiting for surgery. They'll go ahead and put a pacemaker on them, a non-invasive pacemaker, until they can get them to surgery and fix the problem with the heart. A permanent pacemaker goes inside the chest, and it's indicated for chronic or recurrent dysrhythmias. And then these pacemakers can be programmed to have a fixed rate. It fires at a constant rate regardless of what the patient's normal heart electrical activity is. It can also be placed on a demand mode. which it would detect the heart's electrical impulses first, and it can be set at a preset rate only if the heart rate falls below that certain level. So like my mom has a pacemaker, and I think hers is set to fire if her heart rate drops below 60. And so the only time her pacemaker works is if her heart doesn't pump 60 beats per minute, it will kick in and pump for her. So just know there's different modes of pacemakers. Okay, any questions about pacemakers?
Is there any signs for these patients if they're malfunctioning?
There are. Sometimes people can feel their pacemaker kick in, not always. Obviously, if their heart rate starts dropping lower than what it's set at, I would definitely have them call the doctor. The name of the doctor who does pacemakers is called an electrophysiologist. And people that have a pacemaker, they are called, I think it's once a month, and they have this little thing they keep at home, and once they get their phone call, they can just lay this device over their pacemaker, and it does all these kind of readings, and it goes straight to the doctor's office. That way the patients don't have to go to the doctor's office. But most of the time you cannot feel the pacemaker working. Now the batteries do have to be replaced, I think about every 8 to 10 years. My mom has had to go in, I think, once and have her batteries changed. But usually you don't feel when the pacemaker kicks in. And like I said, if your heart rate would start dropping below what it's supposed to, then you definitely probably have a malfunction and want to have that checked out.
Another question, Julie, is so some pacemakers fire all the time, no matter what, and some are backup.
Right. That
doesn't work properly.
When they fire at the same rate, that's called a fixed rate. So, you know, someone might have theirs at 70 and it would just automatically fire to keep their heart rate at 70.
And doesn't someone come from the pacemaker like company and set those so that each person is individualized, and then they have?
Yeah, definitely. Yeah.
And what are the reasons for a patient getting a pacemaker?
Okay, if you have symptomatic bradycardia, if you're my mom, she wore a Holter monitor, and they found her heart rate stayed in the 40s most of the time, and so she immediately got a pacemaker. If you have a heart block, if you have if you have a heart attack, if you have atrial, any tachydysrhythmias, if it's too fast, it can also control that rate. So those are some reasons that you would have a pacemaker. Okay. Okay, so let's talk about premature atrial complexes. This is on page 676. And, you know, when you think of premature, that means too early. So you've got those impulses, they're firing too early. They're sometimes referred to as PACs. You may or may not feel palpitations. Some causes of PACs could be stress, fatigue, anxiety. Sometimes inflammation, infection will cause PACs as well. Caffeine, nicotine from tobacco, they can cause them as well. Usually you don't have symptoms, but sometimes, like I said, patients will have palpitations. Most of the time, no intervention is needed. You just kind of treat whatever you feel is causing it, manage stress. You know, if it's too much caffeine, lay off the caffeine, different things like that. Supraventricular tachycardia. A lot of healthy young people have this. This is a rapid stimulation of the atrial tissue. It can occur, your rate can go up to from 100 to 280 beats, and it can start suddenly and it can just terminate suddenly with or without intervention. And this happens mostly in healthy young people, a lot of times more in women than men. Now, this is a rhythm, atrial fibrillation, and this is the most common dysrhythmia seen in clinical practice. Approximately 6.1 million people in the United States are diagnosed with AFib, and AFib can lead to stroke and or heart failure. The reason is when you have atrial fibrillation, your heart doesn't just pump normally. The atria just kind of fibrillate. They just kind of almost, it's not really a flutter, but you don't get a good beat. And so blood pools in the atria, and that can cause blood clots, which leads to stroke. So it's kind of a chaotic rhythm. On an EKG, there's no clear P wave, and it's just an irregular ventricular response. Some people can feel when they go into AFib, and some people don't ever know they're in AFib. My dad has AFib, has had it for years, and he's never been able to feel anything. So, and then I worked for a doctor that when he would go in AFib, it just kind of incapacitated him. He would have to go in and be cardioverted because that atrial fib was just almost debilitating for him. So some people feel it, have issues, and then some people, you know, may live their whole life and never know they're an atrial fib. Because of that blood pooling, it puts you at risk for blood clots. Obviously, you can have a stroke, or you can also have DVTs, deep vein thrombosis, or pulmonary embolisms. And what happens with atrial fib is you have to be on blood thinner for the rest of your life to prevent those blood clots. Atrial fib is usually diagnosed with an EKG, and then you go on blood thinner.
We had a question, is that the only way they shock the heart back into rhythm? Cardioversion, I guess, is.
Yes. They can also put you on different meds, maybe to help control the rate, but most people just live with AFib. If you're on the blood thinner, then you're less likely to have blood clots form that would cause a stroke. But about the only way you can try to fix it is the cardioversion.
Is Plavix used for any rate conversion?
No,
No.
I don't know about that. Most of the time you take Coumadin, the warfarin, they have like Eliquil. There's some new meds out there. When you're on Coumadin or warfarin, you still have to have your PT or INR checked. And with the new medications, a lot of them you don't have to have the lab work, but they are very expensive. And so you kind of have to make sure whatever the doctor prescribes or whatever the patient wants, they afford it, because some of the medication is very expensive. And of course, most of the patients are going to pick medication you don't have to have weekly or monthly lab work on, but there again, you've got to make sure they can afford it. Okay, so with AFib, your patients, they may feel fatigue, dizzy, have weakness, shortness of breath, chest pain, and again, some patients may not have any symptoms at all. So other than the cardioversion, you can go on an anti-dysrhythmic, calcium channel blockers, beta blockers, digoxin, those types of medications can also help atrial fib. Trying to read through all my notes. I think I've covered everything for AFib. And then when we talk about cardioversion, it's a non-surgical intervention. It's on page 680 in your book. It's the delivery of a direct counter shock to the heart. And now this is going to be opposite of defibrillation. It's a synchronized counter shock. And what it's just going to try to shock the heart back into the regular rhythm. And then after patients have this cardioversion, they're going to be on the anticoagulants for probably, they'll need to be on it before, and then they're going to be on it after. Cardioversion is usually done in ICU. Patients are going to have on oxygen. You would want to document their pre-procedure rhythm. Make sure you have emergency equipment available just in case something would happen. And then during the cardioversion, you would take their oxygen off, put their leads on, make sure everybody's clear. The doctor would do the cardioversion. And then once they get a regular rhythm, that's when it would be over. And then patients need to know that some complications can damage heart tissue. It can also impair heart function. So there are complications possible after you have the cardioversion. And then self-management, they may have to be on an anti-dysrhythmic, anticoagulants after the procedure. And then some healthcare resources. They may also have cardiac rehab, and then a good resource is the American Heart Association. Okay, so let's talk about ventricular dysrhythmias. These are more life-threatening than atrial dysrhythmias because the left ventricle is what pumps oxygenated blood throughout the body. So these are the most common, and they're also the most life-threatening ventricular dysrhythmias.
Julie, before you start that, there were a couple of questions and I just about missed them, but
Okay.
One of them asked, what's the difference of the two shockings? And then are they painful for them to have them done?
Well, the cardioversion is the delivery of a counter shock to the heart. It's synchronized to the QRS. It's synchronized with the regular heart rhythm. A defibrillation, when you're shocked with a defibrillator, it has an unsynchronized direct counter shock to the heart. It stops all the electro activity of the heart, and that allows that SA node, the natural pacemaker, to take over and reestablish the perfusing rhythm. So I'm not sure there's a great difference in the shocks, but yes, the patients are put to sleep, or they're heavily sedated before these shocks because yes, it can hurt.
Do you want us to know the difference amount of joules used for synchronized cardioversion
No,
compared to defibrillation?
no, we're not
Okay.
going that deep. No,
All right.
no.
Okay, so if someone's like dying, they like use defibrillation. Is
Right.
that more right in my head?
Right.
Like if I'm watching
Yeah.
that in a movie and they're like dying and they shock them, they're doing not the cardioversion.
Right. Right.
Okay.
Okay, so these are some EKGs that show ventricular dysrhythmias. The top one, A, is a normal sinus rhythm with a unifocal PVC, premature ventricular complex. And so these really aren't going to make any sense to you, but you can see how, you know what a normal sinus rhythm looks like, so you can see a difference there. So a PVC, a premature ventricular complex, is common. Their frequency does increase with age. They may be insignificant, or they may occur with problems like MIs, chronic heart failure, COPD, anemia. A lot of postmenopausal women find that when they take in a lot of caffeine, they start having, it feels like a palpitation. And it's kind of, you feel a kind of a chest discomfort, and sometimes it even makes you want to cough. I have them occasionally. Some women realize they're having them. Some people, women may be totally asymptomatic. So if you don't have any underlying cardiac disease, there's not going to be any treatment. You know, if it's the caffeine, you want to stop the caffeine. You know, maybe if your electrolytes are off, you want to replace those. So you're going to just treat the cause if it's known. Now this is a EKG strip of sustained ventricular tachycardia. This is called VTAC. It's a repetitive firing, usually 140 to about 180 beats per minute. This can occur in patients, again, who have heart disease, they've had or having a heart attack, drug toxicity. In patients who go into cardiac arrest, ventricular tachycardia is usually the initial rhythm before they start deteriorating into ventricular fibrillation, which is known as the terminal rhythm. So again, if you have ventricular tachycardia, the treatment would be cardioversion and then maybe some anti-dysrhythmic medications. Ventricular fibrillation, it's also called VFib. You'll see it's just a lot of electrical chaos there. It's life-threatening. The ventriculars just quiver. There's no cardiac output. There's no pulse. So therefore you don't have any perfusion. Very rapidly fatal if it's not ended within 3 to 5 minutes. And patients that go, I see I already said that. So there's where I was. This VFib could be the first indication that you even have cardiac disease. Patients who have had an MI are more at risk to go into VFib. A patient, if they're going into a VFib, they become faint, they may lose consciousness, there's no pulse, they're apneic, they could have seizures, those types of things. So you would want to defibrillate immediately if you had an AED, or you would begin your CPR. And then ventricular asystole, or ventricular standstill, this would be complete absence of any ventricular rhythm. So then management of cardiac arrest, you could do CPR. Everyone should be certified. And then you can also get certified in advanced ACLS, advanced cardiac life support. And so here is defibrillation is an asynchronous countershock that depolarizes critical mass of the myocardium simultaneously to stop the circuit and allows the sinus node to regain control of the heart. And then this next slide talks about the AED. It's mainly for lay people to use in response to a cardiac arrest. Okay, so a few questions here. The nurse working in an outpatient setting identifies which dysrhythmia as the most commonly diagnosed?
A.
A, very good. Atrial fib, that's the most common dysrhythmia out there. Okay, a patient is admitted to a telemetry unit with a new diagnosis of AFib. The patient states, I feel fine, this rhythm won't hurt me. Which nursing response is most appropriate?
A.
A, good. Yeah. Patients need to understand that, you know, it just because they can't feel it doesn't mean it's not going to affect them. So yeah, A is the answer. Okay.
I have some questions again.
Okay. Okay.
I'm full of questions.
You are.
Is the defibrillation what a defibrillator does? And I don't want anybody to ever think that those are silly questions.
So say the question again.
Does a defibrillator do the defibrillation?
Yes.
So Julie, with the internal defibrillator pacemaker, it's doing basically the same thing as this defibrillation?
Well, no. So you're talking about an implanted defibrillator. Is that what you're talking about? Whoever asked the question?
That was Melissa. That was
Yes.
Melissa.
Yes, that's what I'm talking about.
The implanted. No, that's different than a pacemaker. A defibrillator is patients, I think with a defibrillator, patients can actually feel the shock because it's going to shock the heart into to a rhythm again. A pacemaker is just going to kind of pick up the beat. If it slows down, it's going to pick up the beat and get it back up to the rate that it's supposed to be at.
But an internal defibrillator will do basically the same thing as an external defibrillator.
Yes, yes.
Okay.
I think that's what she was asking.
Yeah, my dad has one of the internals, so I was just wondering exactly what it does, because he said several times he could feel it like shocking.
And I've heard patients say they definitely can feel the internal defibrillator. Yeah.
They say that it hurts a lot. I've actually had a patient that had an internal defibrillator keep going off and misfiring, and we had to turn it off by like a magnetic strip.
Uh-huh. Wow.
So yeah, that's fun.
My grandpa had one, and he was at the downstream buffet with a huge plate of food, and it went off, and he threw his plate up in the air.
Shocked him.
Got everybody's attention.
Yeah.
Another question is, what would be causes of the ventricular asystole? I think maybe they just missed that.
Let me get back to my screen here. That's going to be death if you go into asystole. You could have a heart attack. Trauma, chest injury. You could choke on something without oxygen, be deprived of oxygen. Numerous causes for ventricular asystole. Heart failure.
Okay. One more question is, do the students need to know all these definitions and abbreviations?
No. A lot of this is just kind of for your information. It is, I want you to know, like the heart rate for bradycardia, tachycardia. But as far as the specific rhythms, no. Now, I do want you to know about AFib. That's probably the only one, because you will see that you'll have a lot of patients in the hospital that come in for AFib.
Another question just now is, if a patient were in a ventricular asystole, the chest compressions begin immediately, or
yes,
or a defibrillator.
Right, yes. Yes. Any more questions?
You had said that there was no medication for the tachycardia, but this may be stupid, but the beta blockers, do they not take care of that?
Yeah, they can slow, beta blockers can slow your heart rate. Yeah, so it can be treated with medication. Tachycardia. DIG can be given for that.
I'm sorry, Julie.
It's
Do you
okay.
equate to defibrillation with VFib and asystole only?
You're getting a little deeper than my mind works.
Sorry, that's
Blaine,
my question.
I
What's
see
your Kelsey
that.
question.
Blaine or Sasha might know.
You don't shock asystole.
You cannot shock asystole. That's
Okay.
bad. Don't do it. You're only damaging the heart.
Right, because you are going to get damage to the heart tissue when you shock.
But I mean, technically, one could say they're already dead.
Okay, that's what I was gonna ask. Like, so what do you do?
Okay, so asystole, all you can really do is chest compressions, pushing epinephrine.
Yeah.
Yeah, you can't, I mean, you can't shock that because there's no electrical current going on, so there's nothing really to shock. You're just damaging the tissues.
Oh, okay.
But you can,
Let 'em die. Cool.
shock VTAC and, what am I missing? Anyways, but yeah, asystole is a no-go.
Okay. Let him die. Cool. You got it.
They're already dead.
VFib is what you shock. My bad.
Okay, so let's take a break and we will come back and talk about peripheral vascular disease and arterial disease. What time is it?
2:07.
And come back at 2:15. So you have 8 minutes.
So you don't use a defibrillator with asystole.
Right. You just
Absolutely.
You do not.
It is a bad, like, you absolutely do not. And that's why I hate medical TV shows, which they're getting better at it. But, like, you see a patient flatline, it's immediate compressions, immediate slamming of the epi, which you can go multiple rounds, but if they're not getting any pulses back and they're staying in asystole, majority of the time, they won't convert.
Okay, cool.
So when you say shock, you mean defibrillation.
Yeah.
Yeah.
Right.
Okay.
Right.
So the only thing that you should like immediately be like, okay, shock them is VFib.
VTAC, VFib, PEA.
Well, the other ones she was
PEA,
saying do the cardioversion first. Everything else she was like, you should use the cardioversion first before you defibrillate.
It honestly, it depends on the situation because there's some, like if you're in the room and you see a rhythm change like that, you can shock that if it's a shockable rhythm.
Got it.
However, you walk into your patient's room and they're just laying there and then you're like, oh shit, like what's going on here? And yeah.
It's kind of like an emergency versus this is ongoing and they're living with it kind of thing.
Also, PEA, you cannot shock PEA usually.
What the hell is PEA?
Believe me, they shock them in the ER.
Premature
I've been there.
That one?
No. PEA. I'm telling you right
activity.
now, I've had my ACLS card. They tell you not to shock PEA.
Well, you can blame every single doctor in the ER that's wrong then. So.
Kenny.
They
last
shock you.
ditch effort.
Okay.
She works in the cardiac ICU. So PEA.
PEA is pulseless electrical
Activity.
Activity. Thank you.
Thank you, Sasha.
Yeah, you don't normally shock it, but last ditch effort, I've seen them pace it. I've seen them shock it.
Yeah,
I
you
mean,
can try, but they usually don't.
I need her.
So what a PEA is on your rhythm, like on your monitor, what it's going to look like is, you're doing CPR, and whenever you get off of the chest, they'll do a rhythm check. It's going to show a rhythm, and sometimes it looks like a normal sinus rhythm. Sometimes it's a little different, but you get off the chest, they check it, you see a rhythm, and you look and you feel for their pulses, and there's no pulse. Like, it's kind of weird to see, but PEAs they don't normally convert either, depending on the person. Sometimes they can. Oh! My big black behemoth. You gonna say hi?
You said his name was Maverick. My son's name Maverick.
Yeah, that's Maverick. He was the one that was like freaking out yesterday because my grandma got home. He does that after every time someone comes home. He's like, "Ah!" Like goes crazy because he loves people.
So many PowerPoints. I wish there was one and it was all in the same thing.
No.
There are too many.
Yes, I just need one.
Sorry.
No, it's okay. I had saved the one we just did, like with skills as its name and not theory. So that's why I was like, I can't find this. I can't find this.
Yeah.
It's under skills, Kelsey. It's under skills.
I know, and I had it the whole dang time too, and then I couldn't find it, so then I just went back into D2L.
Well, I had them all printed out in on my desk, all paper clipped together, and it's kind of like, wait a minute, where are we?
What did I do with it?
And I still have one more for Thursday that I haven't posted yet.
I hadn't printed it. I printed everything you did for today.
We'll have one more.
The first or the last, I guess it was respiratory. You did it all in one.
I like,
one.
Well, this one, I never know what I'm going to put together. There's so many things to go over that I kind of have a hard time deciding. And then we kind of switched it up this semester. And so I had to kind of combine things that I hadn't normally combined before.
Well, let alone that we kind of got thrown a loop in the middle of this semester. I mean,
yeah, just a little bit.
I had to come outside. I'm getting claustrophobic in my house.
Right.
I like to be at home, so I'm kind of liking this teaching from home.
I don't mind being at home, but today I just feel a little on the claustrophobic side because I've been sitting at my table all day.
Yeah.
I wouldn't mind if my kids weren't here.
Send them to Dad.
Yeah.
Is there any way?
My grandson, so I'm enjoying this.
Yeah.
Is there any way Thursday you could do like a small review of what you really want us to make sure we got in our notes?
I don't know because our days are pretty well packed. We'll just have to see. I know I won't be able to this week. So probably not before the test.
Hey, Julie.
Uh-huh.
So if for some reason we can't make it to class Thursday, like if said person has a doctor's appointment, should I try and reschedule that because of that whole quiz thing we got going on, or should
Zoom recording? And I'm going to share my PowerPoint. Okay, what are you all seeing?
Blood pressure being taken.
Do what?
We see your PowerPoint.
Yeah.
Your
Just-
PowerPoint.
just-
Vascular disorders.
Okay, just the screen?
Yeah.
Slide, I mean, okay. Okay. All right, so peripheral vascular disorders. So I don't want to make a real big deal about essential or primary hypertension and secondary hypertension, but I want you to know the difference, and it's not real difficult to understand. So essential or primary hypertension, that is going to be on page 721, table 36-1. It's the most common health problem seen in primary care. Can obviously cause strokes, MIs, kidney failure, death if not treated, but it's not caused by an existing health problem. So essential hypertension, patients that have this type of hypertension can have damage to vital organs. Some common risk factors for hypertension: obesity, smoking, stress, family history, excessive sodium intake, and you can read on for those. So the desired blood pressure for ages 60 and above is 150/90. And then for people younger than 60, it is 140/90. Now that is coming from the Iggy book. Might be different in your fundamentals book, I'm not sure. Now, secondary hypertension is a hypertension that can be caused by disease states like kidney disease, maybe an adverse effect of some medications. And so if this is the case, if a patient has secondary hypertension, treatment would just involve removing the cause. So whatever, if they know what's causing the high blood pressure, you can just remove that, and then hopefully their hypertension would be resolved. Some common risk factors for secondary hypertension is renal or kidney disease. This is probably the most common reason patients have secondary hypertension. Primary aldosteronism, and then you can read the rest. Cushing's syndrome. Some medications like estrogen, when we talked about birth control pills, estrogen can cause high blood pressure. Steroids. Also, some people get gestational diabetes, or hypertension, so they can just have hypertension when they're pregnant. So if this secondary hypertension, if it goes prolonged, if it's untreated, if it's poorly controlled, it can cause peripheral vascular disease, and that can affect the heart, it can affect the brain, the eyes, the kidneys. So you want to make sure this is treated if possible in our patients. So again, when we do an assessment on patients for peripheral vascular disease, you're going to start with patient history. Again, review risk factors for hypertension: age, gender, ethnic origin or race, family history, those types of things. Now, the difference with hypertension versus cardiac disease, a lot of people that have hypertension, they don't have any symptoms. So a patient may come to the doctor, they may be diagnosed with hypertension, and they may have never had any symptoms of it. So they may be pretty shocked. But you want to make sure you take the blood pressure reading in both arms. And make sure you have the proper equipment. Make sure you have the correct size cuff. If you have a larger obese patient, make sure you use that bigger cuff. If you have a very thin patient, you could use even a pediatric cuff. But a lot of patients that have hypertension, if they have symptoms, probably the biggest thing they're going to complain about is a headache. Usually they wake up with it. They may also have facial flushing, dizziness, fainting, and also visual disturbances. And then you need to remember too, when patients go to the hospital or the doctor or even the hospital, sometimes their blood pressure is up, and it may just because they are anxious about being there at the doctor. So if you take it and it's high, go ahead and wait a little bit and then take it again, just to make sure it's a correct reading. Psychosocial assessment, again, they may have just be anxious from being at the doctor's visit, but they may be under a lot of stress. Obviously, you know, stress can affect your blood pressure. Could be their job, could be being stuck at home with your kids. So assess their coping strategies as well. Lab and diagnostic assessment, there is no lab that is going to diagnose hypertension. There are lab work that can identify the causes of secondary hypertension depending on what their disease process is. So, you know, a BUN, creatinine, that's going to be indicative of kidney disease if it's elevated. If you have elevated serum corticoids, that could detect Cushing syndrome. Elevated blood glucose, you know, that could be diabetes. So those are different things that you can look at in relation to secondary hypertension. An EKG could be done because that's going to assess their cardiac function, and then a chest x-ray could also be done. So lifestyle changes, that is what's going to happen with patients who have hypertension. Lifestyle changes are considered the foundation of hypertension control. Most patients are going to be placed on a sodium restricted diet. That's going to be probably a 2 to 3 gram per day sodium diet. They're not going to like it because the food will definitely taste different if they're used to using a lot of salt. Weight reduction is another change they're going to have to make. It's okay for them to begin slowly and then advance. They need to be sure and be under the guidance of a healthcare provider or maybe even a physical therapist. Reduce alcohol intake. Limit alcohol intake to 2 servings per day for men and then 1 serving per day for women. And then exercise, again, under the direction of their PCP, 3 to 4 times a week. Make sure to throw in some aerobic exercise as well. And then try to decrease, try to decrease your stress level. Sometimes that's really hard for patients to do, but you can suggest things like yoga, massages, even hypnosis, or just any other form of relaxation. Maybe they like to go outside and garden. So just suggest something that they really enjoy doing. Smoking, you want to try to get them to stop smoking if they do smoke. They can use nicotine replacements like the gum lozenges or patches. They can use those. There's also Chantix, different medications that they can go on to help them stop smoking. And then complementary or alternative therapy, sometimes different herbs like garlic, that has been said it can help with blood pressure, CoQ10, acupuncture, different things like that. Now, as far as medications, I'm not going to go over these in depth because we've already done that. It's all listed in your pharmacology PowerPoint. And they're also talked about on page 725 in your ICHE book, chart 36-1. There are many medications that can be added to a patient's treatment to treat their hypertension if their blood pressure does not respond to the lifestyle changes by themselves. So usually doctors will try the lifestyle changes first, and if that doesn't work, then they will start adding medications. The diuretics, hydrochlorothiazide, we have the loop diuretics, the Lasix, or then the spironolactone. Those are the medications that doctors usually use first to try to decrease the blood pressure. But a lot of times patients require combinations of medications to control their hypertension. When patients start on medication, they need to make sure they change position slowly. They need to be aware of that orthostatic hypotension. Be careful when they're getting out of bed, when they're driving, those types of things. They need to be careful until they know how the medication is going to affect them. Because if they've never been on blood pressure medicine before, it could just totally bottom them out. And so they need to see how the medication is going to affect them first. Home care management. They need to understand that their hypertension is a chronic illness. It's probably not going to go away. It's best to develop a plan with the patient, kind of let the patient be in a little bit of control. That way they're more likely to adhere to their blood pressure treatment. They need to understand that just because maybe they don't feel like they have high blood pressure, they still need to take their medications. Make sure they have received verbal and written education about their medications, and they have information about the adverse effects. And again, make sure patients can pay for their medications. Sometimes the doctors don't keep that in mind. There's a medication maybe they always use and that's what they want to use. But if the patients can't afford it, they're not going to go get it filled and they're not going to take it. So that's where you kind of have to stand up and be a patient advocate and say, well, they can't afford this, but, there's, the $4, $9 medications that patients can hopefully afford at Walmart. They also can get a blood pressure cuff. They need to be taught how to take their blood pressure, maybe morning and night. And then the patients need to also know that the medications they're on, they may cause some adverse effects, and they need to call and report those to their doctor. Healthcare resources, again.
Cassie, did you get your question answered?
Do what?
Cassie had a question about, I think, which medication was used first. So I just wanted to make sure that she got it answered because some of the students were interjecting.
Okay, what was the question? I haven't answered.
She just had time. Which one was used first?
Oh, the diuretics is normally used first. Now that's not, it's going to be dependent on the doctor, but that's usually the first medication they'll start with is diuretics. Okay, so evaluation, when you evaluate your patient, use the teach-back method. Don't just pour all this education into your patient. Ask them questions with the teach-back method. Make sure they understand their plan of care. Make sure that they can adhere to it. Don't let them set themselves up for failure, because sometimes that's what they'll do. Sometimes patients will have a hypertensive crisis. This is on page 727. Patients that don't follow their plan, don't follow their medication regimen, they can have a hypertensive crisis. Some physical assessment signs would be a severe headache. They have extremely high blood pressure. It could be 180 over 120. And anytime you have a blood pressure this high, it can cause organ damage to the kidneys or the heart. They also may have blurred vision, dizziness, be disoriented, epistaxis, which is bleeding from the nose. So if you have a patient that is experiencing this, more likely they're going to be in ICU. You're going to be administering IV antihypertensive. An IV antihypertensive acts very quickly. It's usually they're vasodilators. You want it to decrease the blood pressure quickly, but not by more than 25% within 2 to 6 hours. So you don't want it to go down drastically. You want to gradually reduce that. Rapid reduction can cause a heart attack. It can cause renal failure. So you want to reduce that slowly. And then you can read the rest on the screen there. Okay, so let's talk about peripheral vascular disease. That includes peripheral arterial disease and peripheral venous disorders. Both of these interfere with normal blood flow. Peripheral arterial disease affects the arteries. That's going to be the vessels that carry the blood away from the heart. And then the peripheral venous disease is going to affect the veins. And of course, that's blood vessels that carry the blood toward the heart. It affects the legs much more than the arms. And so when a patient gets a diagnosis of peripheral vascular disease, it's usually arterial involvement versus venous involvement. So let's talk about peripheral arterial disease, PAD. It is a chronic condition in which partial or total arterial occlusion decreases perfusion to the extremities. And PAD is a result of systemic atherosclerosis. You know that atherosclerosis, there's a formation of plaque in the arteries, and that's made up of cholesterol, lipids, and proteins, which is the leading risk for cardiovascular disease. And it usually affects the larger arteries, the coronary artery, the aorta, the renal, iliac, and femoral arteries, or it can be a combination of all of them. So some risk factors for PAD. I'm not going to read all of those. You can see what they are. So when you are assessing your patients for PAD, if you'll look on page 732 in your book, chart 36-3, most patients don't experience symptoms in the early stages of disease. And then most patients aren't diagnosed until they start experiencing leg pain. That's usually what takes them to the doctor, and that's when they get their diagnosis. Initially, patients will seek treatment for classic leg pain, and it's known as intermittent claudication. This is where they can walk only a certain distance before they start having a cramping, burning, muscle discomfort, or even pain. This forces them to stop walking. After they rest for a while, the pain goes away, then they start walking again, and then the pain returns. And this is called reproducible pain. Rest pain is numbness or burning pain primarily in the feet when they're in bed. Usually this is located in the toes and in the foot arches, or in the forefeet, which is the front part of the foot, and also can be felt in the heel as well. So this type of pain is relieved by placing the legs at rest in a dependent position. And so that means they're hanging down kind of in a dangling position. So this is the only way they can relieve their pain. Physical assessment.
Julie, this assessment is for the peripheral arterial disease, correct?
Yes. The PAD, yes.
PAD, okay.
Uh-huh.
Grace also asked, are there any specific risks they need to know? And I think Grace is talking about the PAD.
Not any specific. I mean, you can kind of, just from what we've gone over and what you're learning, you can pretty well, you know, PAD is the result of plaque in your arteries. And so, you know, what makes plaque? high cholesterol. We know diseases can cause peripheral arterial disease, hypertension. I know there's a lot on there. I'm not saying that you need to memorize all of them, but just kind of think about it when you think about the different things that we've gone over and what we've learned thus far. Does that make sense?
Oh, Grace said.
What'd she say?
She said yes.
Okay. So on physical assessment, decreased capillary refill of the toes. You're going to have decreased or non-palpable pulses. You would want to palpate the pulses in both legs. Mainly the posterior tibial pulse, which we know that is inside of the ankle. And then you would compare those bilaterally. Hair loss, dry scaly, pale or mottled skin, thickened toenails. The extremity can be very cold. Dependent rubor. This is a picture of, remember rubor is kind of a dusky red color. This is a picture of a dependent rubor in the leg of a patient with PAD. Muscle atrophy, and then ulcers and possible gangrene of the toes. You can have sores, start on the toes. They become gangrene because of the prolonged lack of tissue perfusion. Arterial and venous ulcers, they differ from diabetic ulcers. They are very painful. Diabetics, they don't have feeling a lot of times in their feet, and so they don't feel those. But arterial ulcers are very painful, and they usually develop on the toe. So you can see how dark this toe is right here. So that's the development of an ulcer.
Would the yellow be fungus?
It could be. Or it could be the lack of oxygen.
Julie, would they remove that toe? Or what would they do with that?
It depends on, they could do wound care. It just depends on if they could restore blood flow. We'll talk about some procedures here in just a little bit that they can do maybe to restore normal blood flow. But if they couldn't, once a toe starts looking like this and gangrene sets in, a lot of the times they would have to amputate. Okay, so let's talk about some diagnostic assessments for PAD. MRA, which is a magnetic resonance angiography. It's a commonly used diagnostic test because it assesses blood flow in the peripheral arteries. And how it works is a contrast medium is injected to help visualize the blood flow through the peripheral arteries. Some other diagnostic assessments, a Doppler probe that can check the blood pressure measurements in the lower extremities. They could also do the exercise tolerance test. And that helps with the muscle pain. That helps them judge with that muscle pain when they exercise and then when they rest. Arteriography, plasmography is to evaluate arterial flow in the lower extremities, and then also an MRI. You're not going to be tested over those that I just mentioned, except you should know about the exercise tolerance test, but the others, just know that they are diagnostic tests for PAD. So some non-surgical management for patients with PAD, you're going to want to have exercise that's going to increase your circulation in your extremities. Exercise should be started slowly, increase it gradually. Instruct the patient to walk to the point of pain, stop and then rest, and then walk a little bit farther. Also, position changes if your patients are sitting or lying in bed for long periods of time. You can also do position changes, but you want to make sure that patients don't raise their legs above their heart level, because extreme elevation can slow arterial blood flow to their feet. So you want to not raise their legs above their heart level. Avoid crossing the legs, and then also refrain from wearing restrictive clothing or socks. So to promote vasodilation and avoid vasoconstriction, you can provide a warm environment. They can wear insulated socks if their feet are cold. It's really important that patients don't apply direct heat on their skin, because the sensitivity is decreased and it could cause a burn. And then that burn would probably never heal. So you want to also avoid exposures to cold, because cold causes vasoconstriction. And then you also, they need to try to avoid stress, caffeine, nicotine. Caffeine and nicotine can cause vasoconstriction. When you smoke or chew tobacco, you can have vasoconstriction for up to an hour after that, after you smoke or chew tobacco. So, you know, you need to encourage them to stop smoking. Medications, this is where your antiplatelet agents come in, your aspirin and your Plavix. The effects of these medications may not be seen for several weeks. And then, of course, you're going to want to monitor for bleeding. That could be abdominal pain, coffee ground emesis, black tarry stools. They may also be put on your statins. That's your Zocor and your Lipitor. That can also relieve pain that is associated with your PAD. Percutaneous vascular intervention. This is non-surgical, but it is an invasive procedure that's performed by opening the vessel lumen to improve arterial blood flow, and it sometimes involves stent placement. So that is where we were talking about that foot with the black toe. That could they could try that to see if that would improve the blood flow to the foot. Atherectomy. This procedure sounds very painful. It is rotating drills or a laser, and it's used to improve blood flow to patients who have PAD. It's kind of like a rotoblader device, and it will scrape the hard surfaces off of the arteries, the plaque, and they try to not damage a lot of the vessel surface. But they do have a way that they can go in and try to scrape that plaque off the arteries. And then patients who have these procedures will be started on anticoagulants before, during, and after the procedure for a blood thinner. And so nursing care for those procedures, you would just observe for bleeding at the arterial puncture site. You would want to check the distal pulses in both legs to make sure they are having adequate perfusion and oxygenation. Make sure they're on their anticoagulant therapy. And then they'll stay on the anticoagulant therapy for probably 1 to 3 months after those procedures. Surgical management would be arterial revascularization. It is the most common surgery used to increase arterial blood flow in an affected limb. And then you don't need to know any more about that. Okay, so on to peripheral venous disease. These are problems, diseases or disorders with the veins. This interferes with the adequate return of blood flow from the extremities. So you know there's superficial veins and there's also deep veins in the lower extremities. And in these veins, you can develop a venous thromboembolism, venous insufficiency, and varicose veins. So let's talk about venous thromboembolisms first. And this term includes a thrombosis and an embolus. So a thrombus is a blood clot. Usually blood clots result from venous stasis that might be sitting too long. It could be from an injury. It could be the result of a disorder, hypercoagulability. But anyway, a thrombus is a blood clot that forms in a vein. And when that thrombus develops, inflammation occurs around that clot. The vein wall gets thicker, and then you have the formation of an embolus. And an embolus is anything that travels through the blood vessels until it reaches a vessel that is too small to let it pass through. And so when this happens, the blood flow is stopped by the embolus. And then the embolus, often a small piece can break off, a clot, and then that can go to your lung, which is called a pulmonary embolism, which we're not going to talk about that today. But anyway, you will have a lot of patients that are admitted with a blood clot. A deep vein thrombosis. This is the most common type of thrombophlebitis. So a DVT can occur in the arms and the legs, but usually occurs more in the legs. Risk factors, a lot of times after surgery, patients are going to be more at risk, maybe after a hip surgery, total knee replacement. Patients that have heart failure are more likely to have a blood clot, immobility, pregnancy, your oral contraceptives, and then possibly patients that have cancer. Joint commission. Here again, we have another core measure for a venous thromboembolism, and they just hospitals have to report prophylaxis and management of blood clots on their patients that come in. So what are you going to see in your patients if they come in with a blood clot? They may be symptomatic or they may be asymptomatic, but the classic signs of a blood clot is calf or groin tenderness or pain. They have the sudden onset of unilateral swelling of a leg, so that's just going to be one side. In the past, we have checked for a Homan sign. That's where you straighten out the leg and you point your toes towards your head, and if they had pain in their calf, that could be indicative of a blood clot. But this appeared only in a small percentage of patients, so it's not advised to use this sign anymore. You are going to see localized edema over the affected area. Now, if you would have a patient that is short of breath and have chest pain, this would be indicative of the clot moving to the lung, which would be the pulmonary embolism. Also, they could have venous studies, that would show the clot. They can have an MRI, a D-dimer. This is going to be talked about on page 743 in your book. It is a global marker of coagulation activity, and it measures the fibrin, which is the last stage of blood clotting. It measures the products of the fibrin. And it is used a lot for the diagnosis of a DVT when the patient has few clinical symptoms. If the D-dimer is positive, it can indicate that there is a blood clot. It's not 100%. That is not the only test you would want to go by, but it is useful as an adjunct test to a non-invasive test. And then a negative D-dimer can exclude a DVT. So if it's positive, you want to have another test in addition to that. It could just be used in adjunct with another test. But if you have a negative D-dimer, you pretty much don't have a blood clot. So that's what a D-dimer, that's a lab test. So the focus of managing a blood clot is to prevent complications such as a PE and to prevent further thrombus formation. So there's non-surgical management, and then there is surgical management. So
Hey, Julie, I'm sorry. Will it kick us off if we go out of our time limit?
I don't think so.
Okay, I just wanted to make sure.
No. Okay, no, I think it'll be fine until I end it.
Okay.
Okay.
Thank you.
You're welcome. Non-surgical management, rest. They used to always put patients on bed rest when they came in with a blood clot in their leg. But they have found now that ambulation does not increase the risk for pulmonary embolism. But there again, it's going to be whatever the doctor orders. Some may keep them on bed rest, and some may let them get up and walk around to the patient's tolerance. You don't want to use pillows under the knee. You don't want to have anything constricting on the leg. It is good to elevate the leg when they're in bed or in a chair. And they also will probably wear knee-high or the thigh-high TED hose. Some primary care physicians will also order warm, moist soaks to the leg to help ease the pain. And one thing you want to remember is you never want to massage the affected extremity. You don't want to dislodge that clot and allow it to become an embolus and move around in the patient. So if you have a patient that has a blood clot, you want to monitor for signs and symptoms of a PE, a shortness of breath, chest pain, acute confusion, things like that. Medication therapy, they're probably going to be started on IV heparin. Remember, you go on heparin first. And heparin is given to prevent the formation of other clots and to prevent the clot that they have from becoming bigger. Of course, IV heparin has to be started in the hospital. You're going to monitor your lab work, your PT, PTT, INR. You might want to monitor the CBC, make sure they're not having bleeding. You could monitor a UA as well. You might check a stool for occult blood to make sure they're not bleeding. You also want to monitor for heparin-induced thrombocytopenia. This would be a platelet count that would be less than 150,000. And then make sure the protamine sulfate, that's the antidote for heparin, is available if your patient would start having bleeding. There's also Lovenox, enoxaparin, the low molecular weight heparin. I think we've talked about that. This is where I've got about it's based on the client's weight. And so a dose is 1 milligram per kilogram of body weight, and you're not to exceed the 90 milligrams. So that's how the Lovenox dose is figured. So it goes off of the kilogram of body weight. A lot of times patients with a DVT, after they have been taken off their heparin, They may go on the warfarin or Coumadin while in the hospital, and then when they're discharged, they can go on the Lovenox, because a lot of patients can give their own sub-Q injections at home. In that case, you would have to instruct your patient to watch for bleeding, use the bleeding precautions, maybe an electric razor instead of a bladed razor, use a soft toothbrush, etc. Warfarin, they may go on that orally to try to get them off of the heparin. And then again, you're just going to monitor for the same things. With warfarin, the antidote is vitamin K. And so you would want to make sure your patient understands to lay off of the green leafy vegetables that are high in vitamin K, high sources of vitamin K.
Julie, Savannah has a question.
Okay.
She said that she was, let me read this. She was sent home on Lovenox after her accident. She had a fatty embolism. So is this treatment the same for fatty embolism? Or do you know?
I don't know. I don't know. I'm not, I don't know. That's all I can say.
That'd be something good to look up, though.
Right. Look it up and let us know. Let us know next time.
Look it up.
Look it up.
Kristen, that's a great question.
Okay, so surgical management, they can have a thromboectomy. I think I spelled that wrong. They can remove the clot. It's rarely removed surgically, but they can remove it. This is going to be for patients with recurrent DVT, or if they've developed a PE and they don't respond to any medical treatment. If they can't tolerate the anticoagulant medication, they can also use a filter. I think a lot of them is called a Greenfield filter. And this is a device that's put either in the femoral vein or the jugular vein, and it kind of traps that blood clot, the emboli, before it gets to the lungs. So that is surgical management there. Home care, patients need to be educated about their anticoagulation therapy. They're going to be managing that at home. I know my dad's on warfarin, and so, he has orders according to whatever his INR is. He may take one pill Monday, Wednesday, Friday, and Tuesday, Thursday, he may take a half a pill. And so they need to know that, whatever they go home on may not continue to be the same. It could change. Self-management, stop smoking. Females need to avoid the use of oral contraceptives. And then we talked about the core measures already with Joint Commission. Evaluation, you want your patient to be free of injuries associated with blood clots. Okay, venous insufficiency. This occurs secondary to damaged valves in the deeper veins of the lower extremities, which allows the pulling of blood, and because of that pulling, it causes those veins to dilate. Stasis dermatitis, you'll see this a lot in older adults. It's kind of a brown discoloration along the ankles, and it can extend up the calf. And it just kind of depends on the level of insufficiency of how high up that brown color goes. They also can have stasis ulcers. These are typically found around the ankles, and this is a result of edema or maybe from a minor injury to the limb. Some risk factors is sitting or standing in one position for too long. Obesity, pregnancy, and thrombophlebitis. You want to try to manage the edema. You want to try to get that decreased, promote venous return from the affected legs. So you could elevate the legs, avoid crossing the legs, and then they could also wear compression stockings. Management of the venous stasis ulcers, which are the result of edema. They may need surgical debridement of those ulcers, and that's where they would just go in and debride, cut away all that dead tissue, and allow new tissue to start forming. Usually with the stasis ulcers, it requires long-term treatment, long-term wound care. You also would want to involve a dietitian to help them with their diet to assist with the healing process. Medications, instead of surgically debriding, they can use medication that will debride. There's topical and chemical debridement. It is just a cream or a gel that is put on top of the ulcer, and it will kind of eat away that necrotic tissue, and it promotes healing. Surgical management, this is not performed for chronic venous insufficiency because the surgeries are not ever usually successful. Attempts at transplanting vein valves have had limited success. So pretty much have to depend on medication, diet, and wound care for venous insufficiency. Let's talk quickly over varicose veins.
Julie, we have one question about back to thromboembolism. Is there anything other than massaging the area that could cause that to dislodge? And the specific question was, well, would that Homan's test dislodge? Was that the fear that it might dislodge?
No, the Homan's, no, I don't think it would dislodge it. It's a Homan's test is just mainly to tell whether they have the blood clot in the first place. And it's just kind of been proven it's not really indicative because not all patients that have blood clots have a positive Homan sign. As far as dislodging, that's why a lot of patients are put on bed rest, but research has indicated that you don't more likely get a PE if you get up and walk. Usually if you are started on the heparin, there's not a fear of that usually happening, but that's not to say that a doctor may keep you on bed rest. And that's not to say that it could just dislodge itself and start traveling. Does that answer the question? So I can't, you can't really say that, oh, if you don't massage that area that the blood clot is going to stay put, because it could start traveling on its own.
Yeah, I was just mainly kind of wondering if, if they're doing like, I don't know, exercising or things like that. Like the more strenuous they are,
Yeah.
is that
well, you're not, when they're in the hospital and have first been diagnosed with a DV, you're not going to want them to, they can walk around, but you don't want them to be real active. Yeah.
Right. But if they just have, what if they like have them all the time? What if they're kind of like, they chronically kind of have, is that a thing or no?
Oh, blood clots? Yeah, I guess they could. That would be the hypercoagulation disease. They would just stay on blood clots. I'm sure they would have the filters put in that would stop those clots from going to the lungs.
Okay, thank you.
You're welcome. Okay, so varicose veins, those are distended, protruding veins. They're usually darker in color than other veins, and they're tortuous. That means they have many twists and turns, just kind of ugly veins. Risk factors are female gender, older than 30 years old, occupations that require prolonged standing. So you ladies, when you get over 30 and you're still nursing, you possibly could have varicose veins because we stand a lot as nurses. You can also get them during pregnancy, obesity, heart disease, and then just a family history. collaborative care, you can wear elastic stockings. You can elevate the extremities. There's also sclerotherapy. That is where a sclerosing irritating chemical can be injected into the vein. It causes inflammation. That's going to close the lumen of the vessel and harden, and it eventually destroys the vessel. And so it just kind of almost disintegrates and you can't see it anymore. If a patient would have this procedure, you would put a pressure dressing for approximately 1 week to keep the blood from re-entering the vessel. And then usually would just require maybe Tylenol for pain. They do also surgically remove the veins. If you have the large varicose veins that cannot be treated with the sclerotherapy, they can actually strip those veins out of the legs. And also there is radiofrequency energy to heat the veins. That's where a small catheter is inserted into the vessel, and then it scars and closes the dilated vein. So there's several different procedures that a patient can have for the varicose veins. Okay, so these are just some terms that are on our syllabus under the content topics. And what I have on the slide is all I want you to be generally familiar with. Polycythemia, it's when poly, you know, means many. So that's going to be you have too many red blood cells. You have more greater than normal. And the blood of a patient with polycythemia is hyperviscous, so it's thicker than normal. Increased levels can indicate possible chronic hypoxia or polycythemia vera, which is a cancer of the red blood cells. Can be temporary or chronic. Another term, hematologic disorder, is thrombocytopenia. What I want you to know about this, because you are going to see this term, this diagnosis in the hospital, it's on page 815 in your IGGY book. This is a reduction of platelets. And so, you know, this can occur when patients receive cancer treatments or anything that would suppress the bone marrow. Patients are at risk for excessive bleeding if their blood count, platelet count falls below 50,000. Also, if you will look at page 825 on chart 40-7, this lists the best practices for patients with thrombocytopenia. So the main thing you need to know about that is it's just a reduction of platelets for some reason, cancer, for whatever reason. Another term is a granulocytosis. This is an acute disease deficit or the absence of granulocytic white blood cells. This is the cause of, it can cause leukemias. It's caused by certain leukemias and certain medications and radiation. Another term, multiple myeloma, it's on page 829. This is a white blood cell cancer that secretes antibodies. Without treatment, you have bone destruction, bleeding problems, and kidney failure. And lymphedema, this is on page 1454 in your IGGY book. And this is a collection of fluid, of abnormal collection of tissue fluid in the interstitial spaces. It is caused by an injury or an infection of an extremity. It's usually in one of the arms. It can be caused by obesity, presence of extensive axillary disease, or radiation treatment. Usually women have lymphedema. Sometimes men have it as well. They have to take lifelong measures to prevent it. And the symptoms are a sensation of a heaviness or swelling, aching, numbness, tingling. That's where they wear the tight arm cover over their arm to keep that fluid from going down into their arm. And lymphomas on page 828. And this is just a type of cancer. Now, all these last few things that we've talked about, you won't be tested over, but they are just in our syllabus of things that you need to be familiar with. I want to quickly hit the diets. I know we've gone over. The DASH diet is dietary approaches to stop hypertension. So the DASH diet is recommended for people with high blood pressure. It's been proven to lower blood pressure. It's a low sodium plan, but it also is a diet that's rich in fruits and vegetables, beans, nuts, whole grains, low fat or non-fat. I have a reference page at the end that I don't think was on yours. If you want to find more information about it, you can look in these references. So the DASH diet, just know it is for hypertension. DASH stands for Dietary Approaches to Stop Hypertension. There's also the American Heart Association also has a diet that's very similar to the DASH diet. And then at the bottom of that slide, I have listed more information if you want to read a little more in depth about that diet. And then the last diet is the therapeutic lifestyle changes. TLC is what it's referred to as, and it's for high cholesterol. So you need to know that this diet is for high cholesterol, and then the DASH diet is for hypertension. And then at the end of this, the bottom of the slide, I have given a website that gives a guide on, talks about more in-depth information on this type of diet. So it's wanting to reduce the amount of saturated fat you eat. You know, it encourages fruits, vegetables, whole grains, those types of things. And then here's the reference page if you want to take a picture of that, or I can also post it to D2L. And that's it for today. It's been a long day, I know. Lots of information. Do I still have students? Awake students?
Barely.
Barely, I know.
I think they're all still logged on. I don't know
That's
if they're
awesome.
awake.
Nope, they're here. They're on, but they may not be awake.
Made it.
Okay, that's it for today. So we'll meet in the morning at 8, Kathleen?
Yes, everybody that's in 1217, and Vicki should have got a hold of you for OB if you had a day to make up. That we'll have a Zoom meeting with I think there will be like 37 students that were in 1217 clinical. So I'll send out a link. I think I have figured out how to put that on D2L. I created a Zoom meetings tab under the content, and I think I can just post it there. I'll title each link for what meeting it is. Like I've already posted Julie's afternoon one there to see if it would work. Just put that it was skills number 10. So hopefully that'll work and make it a little easier to find them.
Okay, good. So 8 o'clock in the morning.
Didn't you say on varicose veins it could be inherited too? Because
Yes.
I had my script at 24 and I had them done twice. And then the last time, that was the old fashioned way where they actually took it out. And then the last time was the catheter. But they couldn't do that you see on TV where they put a little needle and they squirt stuff in. They told me that only works for spider veins only.
Yeah, that's the sclerotherapy, yeah. Yeah, it can be inherited. Okay, so we will see you bright and early at 8 o'clock in the morning. At least
Don't forget to stop recording, Julie.
Okay, stop recording.